So, when you think about the booming world of, cosmetic procedures, the expectation is almost always tied to visibility,
Right,
right?
yeah. Like you get a rhinoplasty and your profile is just fundamentally altered in every single photo.
Exactly. Or, you get a facelift and the results are just on public display every time you walk into a room.
Right. The entire premise is basically rooted in the external gaze, people seeing the change.
Right. But the moment you look at this rapidly expanding field of cosmetic gynecology and aesthetic genital surgery, that public display completely vanishes.
It's totally hidden,
Yeah, we're talking about an industry experiencing massive year-over-year growth, but it's focused entirely on the most intimate, hidden parts of the human body.
which is fascinating. And, if you actually start reading the literature surrounding it, you're going to experience some severe informational whiplash.
Oh, absolutely. And that whiplash is exactly what we are unpacking for you today. We are going to navigate this really stark divide between the shiny promises of international clinic marketing and then, the severe, unyielding warnings from the medical establishment.
Yeah, the contrast between the promotional material and the actual clinical reality is just staggering.
It really is. So, to map this out, we're looking at a stack of incredibly contradictory sources today. On one side, we've got promotional literature and patient guides from places like Asabadim Hospitals Group, Center for Surgery in London, and RISA IVF in Delhi.
Right.
And we are pitting those directly against formal medical guidelines. Specifically, we're looking at Committee Opinion number 378 from the American College of Obstetricians and Gynecologists, or ACOG.
Which is a very heavy-hitting document.
Very. And just to be super clear right up front, we aren't here to endorse the clinics or, champion the medical boards.
Exactly. We're simply taking the facts, the marketing claims, and the clinical guidelines exactly as they appear in the sources, and we're just trying to figure out how this industry actually operates.
Right, impartial guides for this deep dive. So, where do we even start? Because the terminology itself is kind of the first hurdle.
It really is. I mean, the source from Aspedium Hospitals Group is super helpful here because it provides a necessary taxonomy.
Okay.
It breaks down a foundational difference between two terms that, frankly, clinics often just use interchangeably, but they actually involve entirely different physiological approaches:
Which is
aesthetic genital surgery and cosmetic gynecology.
Okay, so reading through the Acibadem breakdown, it seemed to me like aesthetic genital surgery is strictly focused on like external contour and physical structure.
Yes, exactly. You're looking at procedures aimed at reshaping the labia, or maybe reducing the mons pubis, or altering the clitoral hood.
So it's primarily about symmetry and visual appeal on those outermost layers of tissue.
Right, it's very structural and external. Cosmetic gynecology, on the other hand, is a much broader umbrella.
Because it includes the aesthetic stuff but adds to it.
Yeah, it encompasses those aesthetic modifications, but it deeply integrates functional concerns too. So you are dealing with things like vaginal laxity or scar repair after, perineal trauma from childbirth.
Oh, wow. And urinary incontinence, right?
Exactly. It involves the much deeper mucosal layers, the actual pelvic floor musculature, and the really complex innervation of the entire pelvic region.
It almost feels like, to use an analogy, aesthetic genital surgery is essentially the exterior landscaping.
Not like a, yeah.
Like it's optimizing the visual appeal, the contouring, the symmetry of the outside. But cosmetic gynecology is dealing with the structural plumbing and the load-bearing walls.
That is a perfect way to look at it. It's addressing the internal mechanics, the support systems, and really how the entire structure holds up under pressure.
Right. And does that mean different doctors are doing these procedures?
It does, yeah. That distinction dictates the specific surgical disciplines involved. The Acibadam source notes that the exterior landscaping, as you called it, is frequently handled by plastic surgeons.
Because they're experts in skin excision and contouring.
Exactly.
Yeah.
But the structural plumbing, that is typically the domain of gynecologists or urogynecologists.
Which makes sense. I mean, altering the functional mechanics of the vaginal canal requires specialized training in female pelvic floor dysfunction.
Right. You wouldn't want a standard plastic surgeon messing with your pelvic floor musculature.
Definitely not. And it makes sense when you look at the complex motivations driving patients to these clinics in the first place, right? The sources show this massive spectrum of reasons.
Oh, huge spectrum. On one end, you have patients dealing with really highly disruptive physical realities.
Like severe chafing of external tissue in tight clothing or recurrent irritation during exercise.
Yeah, or stress urinary incontinence where the pelvic floor simply cannot maintain the seal on the bladder when they laugh or sneeze.
which is a very real physical quality of life issue. But overlapping heavily with that physical discomfort is this layer of profound psychological distress.
Absolutely. Patients are reporting these deep-seated body image concerns or anxiety over natural asymmetry.
Or just a sense of disconnection from their bodies after, say, the massive physiological trauma of childbirth.
Right, or even just the tissue changes associated with aging and estrogen depletion.
So it's this really messy intersection of genuine physical pain and psychological vulnerability.
It is.
But as you sift through these clinic sources, there is a very distinct pivot. While many procedures are framed around relieving that discomfort, a massive portion of the marketing is geared purely toward enhancing sexual pleasure.
Yes, the enhancement angle is huge.
And that leads us straight into the most heavily advertised non-surgical enhancement in our entire stack of texts, the G-shot.
Right, also known in the clinical literature as G-spot amplification.
Okay, break this down for us because it sounds intense.
Well, the mechanics of this procedure are actually fascinating, largely because they borrow directly from facial aesthetics.
Wait, really? Facial aesthetics?
Yeah. According to the promotional materials from the Women's Wellness Institute of Dallas and the Center for Surgery, the G-shot is framed as a quick 10 to 30-minute outpatient procedure.
They literally market it as a lunchtime fix.
Exactly. The process involves the physician using a speculum to isolate the anterior vaginal wall. And then, after applying a local anesthetic, they inject a dermal filler directly into the submucosal tissue.
A dermal filler, like the kind people put in their lips.
Yes, exactly. We're usually talking about hyaluronic acid fillers, like Restylane, Juvederm, or Perlane, or sometimes they use collagen.
Okay, so the physiological goal here is physical enlargement, right? By plumping the Grafenberg spot with hyaluronic acid, the clinics claim the tissue projects lower into the vaginal canal.
Right. The underlying logic is purely spatial. A larger surface area creates more friction during penetrative sex, which theoretically lowers the threshold for stimulation and makes orgasms easier to achieve.
And if we look at how hyaluronic acid actually functions, I mean, it's highly hydrophilic, right?
It is, yeah, it binds to water. So when it's injected into the anterior vaginal wall, it doesn't just sit there. It actively draws in surrounding moisture, creating this localized, swollen cushion of tissue.
Wow. And the clinics really heavily leverage this in their marketing. They emphasize the minimal pain because of the local anesthetics, the immediate tissue expansion, and this remarkably rapid return to function.
Yeah, they claim patients can resume sexual activity in just 24 to 48 hours.
Which is incredibly fast. And the lifespan of the filler is anywhere from 3 to 18 months, depending on the cross-linking of the specific acid used.
Right, so it reads like a highly efficient temporary upgrade.
It does, but the deeper you read into the sources, you hit this massive scientific contradiction.
The anatomy debate.
Yes, I was looking at the brief from Surak Ahmed, and it explicitly states that the very existence of the G-spot as a distinct anatomical entity remains unproven. Studies have repeatedly failed to provide consistent histological evidence that it exists as a solitary defined structure. So, if you're a clinician with a syringe full of Juvederm, how are you precisely injecting a target that the broader scientific community isn't even sure is there?
I know, it's wild.
It feels like trying to hit a moving bullseye in the dark based on a rumor.
Well, that paradox is the absolute core of the debate surrounding intimate injectables. You have clinics operating on a very firm structural belief system.
Right, like they know exactly where it is.
Yeah, Dr. Cedric Cron's site, for instance, refers to it as a proven perennial glandular tissue that approximately 80% of women possess. They are operating under the premise of a fixed coordinate.
They believe the hardware is installed in a very specific location.
Exactly. But the competing medical literature, which is echoed by Surak Ahmed, views the anatomy entirely differently.
How so?
The alternative theory is that the G-spot isn't a standalone button. It's likely a highly sensitive region where the internal crura, or roots, of the clitoris intersect with the urethra and the anterior vaginal wall. It's a complex, interconnected neurovascular network.
So when a doctor performs a G-shot, they might not be hitting a distinct gland at all.
Right. They might just be indiscriminately plumping up a highly innervated region of the vaginal wall, basically banking on the fact that expanding the tissue anywhere in that generalized zone will inadvertently increase friction against the internal clitoral structures.
Okay, that makes sense. That is the prevailing theory among skeptics of the distinct G-spot model.
And To be fair, even within the promotional literature, there are massive caveats.
Like what?
Multiple clinic sources, including the Berman Women's Wellness Brief, explicitly clarified that the G-shot cannot treat emotional sexual dysfunction or low libido.
Well, yeah, because injecting a hydrophilic gel into mucosa does not alter your endocrine system or your psychological state.
Exactly. If the issue is a lack of desire, creating a temporary cushion of tissue isn't going to somehow synthesize arousal out of nowhere.
Right. And we really need to talk about the risks, because the risks associated with this procedure reflect the reality of injecting viscous substances into a highly vascular, tightly packed anatomical space.
Oh, for sure. When you introduce a filler that draws in water and expands, you are creating localized pressure.
And the sources list complications like urinary retention, which happens when that expanded tissue physically presses against the urethra and prevents the bladder from emptying.
Yeah, which is incredibly uncomfortable.
Yeah.
But the sources also list the risk of fistula formation, which is a much, much more severe complication.
Right, a fistula from a temporary filler.
Yes, fistulas occur when the localized pressure from the filler, or even just the trauma of the injection itself, compromises the blood supply to the tissue.
And that causes the tissues to die.
Basically, yes, this ischemic necrosis can cause the tissue wall separating the vagina and the bladder or urethra to literally break down.
Oh my.
Yeah, creating an abnormal tract or opening between the two organs. You also have risks of persistent unwanted arousal due to nerve irritation and localized infections.
Which completely shatters the illusion of the breezy, lunchtime spa treatment.
Totally.
I mean, if a 10-minute outpatient filler injection carries the risk of tissue necrosis and fistulas, I can't even imagine the complication matrix when a patient bypasses the temporary gel and opts for permanent structural surgical alteration.
Right. The surgical route is a whole different ballgame.
Because the texts detail some heavy reconstructive procedures once we move into the operating room.
They really do.
Yeah.
The surgical interventions operate on a completely different scale of tissue trauma. The most prominent is vaginoplasty.
Which involves surgically decreasing the diameter of the entire vaginal canal, right?
Yes. This usually requires excising wedges of mucosal tissue and surgically pulling the separated levator antemuscles back together. It's a process known as colporrhaphy.
Okay. And what else?
Then you have labiaplasty, which is the surgical reduction or reshaping of the labia minora or majora, and clitoroplasty, which is a highly intricate surgery involving the reduction of the clitoral hood while attempting to preserve the massive nerve bundles underneath.
Wow. And the reality of the recovery for these procedures is just jarring compared to the marketing language.
Oh, night and day.
Because a vaginoplasty is not a quick outpatient visit with numbing cream. According to the Women's Healthcare and Beyond source, you are looking at 4 to 6 hours under general anesthesia.
It's major surgery.
And the postoperative protocols are brutal. Looking at the recovery guidelines from the gender confirmation surgery source, the swelling and localized trauma are so severe that patients are instructed to sit on a donut ring just to keep pressure off the perineum.
Yeah, and they have to apply ice for 20 minutes every single hour for the first week just to manage the vascular engorgement.
That sounds exhausting. And the physiological response to surgical trauma in the pelvic region is extreme, right?
Very. The body immediately forms scar tissue, and the natural mechanism of scar tissue in a circular canal is contracture.
Meaning it shrinks.
Exactly. It tightens and shrinks as it heals. So to combat this, vaginoplasty patients are put on a really rigorous dilation schedule.
Right. The guidelines dictate inserting a rigid dilator for 10 minutes, 3 times a day for the first 3 months.
Which sounds incredibly painful when you're healing.
Yeah. You have to physically stretch the healing incisions to prevent the canal from closing in on itself. And then it tapers to once a day for 3 months, and eventually 2 to 3 times a week for at least a year.
Because if the patient fails to maintain that schedule, the myofascial tissue will contract. That results in a permanent narrowing or shortening of the canal, which requires another revision surgery to fix.
And plus, depending on the procedure, sexual activity is completely banned for 4 to 12 weeks to prevent the sutures from tearing under friction.
Right.
The disconnect here is wild. I mean, the clinics use these breezy, almost cosmetic terms like rejuvenation, revirgination, and designer vaginoplasty.
Yeah, they sound like spa treatments.
Exactly. But the reality involves donut pillows, grueling mechanical dilation, bleeding, and months of pelvic rest. It raises a serious question about informed consent.
It really does. Are patients actually being adequately prepared for the gravity of the tissue trauma they're signing up for.
Right. And that gap in informed consent is the primary focus of the warnings from the women's health clinic sources, isn't it?
Yes, they stress that postoperative care is not just a polite recommendation, it is a critical safety protocol. Their literature repeatedly warns clinicians that these surgeries must never be trivialized as routine.
Just because a procedure is common or, marketed heavily on Instagram doesn't neutralize the surgical risks.
Exactly. Patients must be explicitly briefed on the long-term sequelae. The literature highlights severe risks like permanent altered sensation.
Like losing feeling.
Yeah, either numbness from severed nerves or hypersensitivity from neuromas. There's also the risk of wound dehiscence.
Which is what?
That's where the incisions physically separate under tension, leading to chronic pelvic pain. And most ironically, there is a high risk of iatrogenic dyspareunia.
Wait, iatrogenic dyspareunia, what does that actually mean for the patient?
Basically, it means the surgery itself actually causes severely painful intercourse.
Oh, wow.
Yeah, often due to aggressive scar tissue formation, restricting the natural elasticity of the canal.
Which is a devastating outcome when the entire premise of the surgery for many of these patients was to enhance sexual function.
Right, it's a catastrophic failure of the procedure's original intent. And this glaring disparity between the lighthearted designer marketing and the reality of tissue necrosis, contracture, nerve damage, that is exactly what triggered the severe pushback from the medical establishment.
And this is where ACOG, the American College of Obstetricians and Gynecologists, enters the picture with Committee Opinion number 378.
Yes.
Because when you pivot from the clinic websites to this clinical document, the shift in tone is absolute. It is blunt, it's unyielding, and completely divested of any marketing gloss.
Oh yeah. ACOG draws a definitive line in the sand, and they are representing the consensus of one of the most authoritative medical bodies in the field.
The language is highly specific.
Yeah.
ACOG explicitly states that procedures marketed as vaginal rejuvenation, designer vaginoplasty, and G-spot amplification are not medically indicated.
Right.
And they go further to state that the safety and effectiveness of these specific cosmetic procedures have not been documented in peer-reviewed literature.
And the mechanism of their concern is really rooted in evidence-based medicine. ACOG is observing a rapidly scaling industry where patients are undergoing permanent structural alterations to highly innervated anatomy based almost entirely on proprietary clinic marketing rather than rigorous clinical trials.
So they are essentially saying that women are being informed by glossy brochures and before and after photos rather than actual longitudinal data on complication rates.
Exactly. Without that robust data, the true incidence of severe adhesions, dense myofascial scarring, and that iatrogenic dyspareunia we talked about remains dangerously opaque. ACOG's warning is fundamentally about the principle of non-maleficence. First, do no harm. They are terrified that surgeons operating without standardized peer-reviewed protocols are surgically creating the very dysfunction the patient is paying tens of thousands of dollars to fix.
That makes total sense. But ACOG doesn't limit their critique to just the physical surgical risks, right? A major portion of their pushback addresses the psychological framework surrounding the entire industry.
Yes, psychological screening protocols are heavily emphasized in the medical guidelines. Before any patient is cleared for elective genital cosmetic surgery, ACOG strongly advises a comprehensive psychological assessment.
What are they looking for?
A primary red flag they are screening for is body dysmorphic disorder, or BDD.
Right, because if a patient has a profound obsessive fixation on a perceived flaw that is objectively unnoticeable or completely biologically normal, altering the tissue with a scalpel isn't going to resolve the psychiatric distress.
Exactly. The dysmorphia will simply transfer to the surgical result or a different part of the body.
The guidelines also require screening for severe anxiety, clinical depression, or interpersonal coercion, don't they?
Yes, specifically cases where a patient is seeking structural alteration due to external pressure from a sexual partner.
Which is awful to think about.
It is. The medical consensus is absolute on this point. A surgical intervention cannot repair a psychological deficit, and it certainly cannot stabilize a fractured relationship.
So we have official medical guidelines stating there's an absence of safety data, warning of severe complications, and actively advising clinicians to steer patients toward conservative treatments first.
Right. Things like specialized pelvic floor physiotherapy to rebuild muscle tone,
Or localized estrogen therapies to improve tissue elasticity.
or honestly, simply utilizing lubricants.
Right. So if the medical establishment is throwing up this many red flags, why is the cosmetic gynecology industry experiencing such exponential growth?
It's basically a perfect storm of modern physiological and cultural pressures. You have a massive demographic of women experiencing entirely valid physical realities.
Like postpartum pelvic floor trauma.
Yes, that is real. The thinning of mucosal tissue during menopause is real. The distress caused by stress urinary incontinence is undeniable.
Right.
But that genuine distress is being intercepted by an industry utilizing incredibly aggressive cosmetic marketing tactics.
It sounds like a massive vulnerability exploit. They are taking legitimate physical discomfort and weaponizing it.
And the insidious part is how the marketing pathologizes normal anatomical variations. The medical sources plead with clinicians to educate their patients on the vast spectrum of normal female anatomy.
Because they were taking biological variations that have existed since the dawn of humanity, defining a ridiculously narrow window of what is aesthetically acceptable, and framing everything outside that window as a flaw requiring a designer intervention.
Yes. The medical establishment's core fear is that patients are being sold an artificial standard of normal that doesn't actually exist in nature. The industry is essentially creating a psychological deficit and then selling the surgical solution to resolve it.
Which perfectly encapsulates the whiplash of this entire deep dive. The landscape of cosmetic gynecology is a sprawling matrix of contradictions.
It really is.
On one end, you have the outpatient interventions like the G-shot,
No.
injecting hyaluronic acid into a highly debated anatomical zone, banking on temporary tissue expansion to enhance localized friction, while risking complications like urinary retention and fistulas.
Right. And on the other end, you have major structural reconstructions like vaginoplasties and clitoroplasties.
Right, which involve general anesthesia, the excision of tissue, the suturing of the levator ani muscles, and months of grueling recovery.
Months of donut pillows, ice regimens, and rigid dilation schedules to prevent severe tissue contracture.
Yeah. The private clinics are promising enhanced pleasure, restored youthfulness, and psychological confidence through rejuvenation. Meanwhile, ACOG and the medical establishment are sounding alarms over unproven safety, undocumented long-term efficacy, the risks of chronic pain, and the absolute necessity of psychological screening to ensure patients aren't trying to solve a mental health crisis with a scalpel.
It is the ultimate clash between the relentless innovation of aesthetic medicine and the rigid, cautious realities of evidence-based clinical practice.
And as we close out, there is a lingering thought worth exploring. The sources we reviewed are intensely focused on how these procedures alter physical tissue to fix perceived dysfunctions.
Right.
But looking at the trajectory of this industry, you have to wonder about the cultural catalyst. How much of this demand is actually driven by medical necessity or physical discomfort? And how much is being quietly engineered by the omnipresence of digital media, photo editing, and pornography?
That's a huge point. We are living in an era of artificially standardized aesthetic ideals.
Exactly. Are we reaching a point where we are utilizing major reconstructive surgery to force human anatomy to mirror the impossible filtered reality of a screen?
The normalization of those digital ideals is undoubtedly shifting the baseline of what patients consider physically acceptable.
It fundamentally changes how you perceive the entire concept of exterior landscaping. Thank you for joining us on this deep dive. The next time you encounter a shiny marketing brochure promising a quick fix, remember the underlying mechanics of the plumbing. Keep questioning the consensus, stay curious, and we will see you on the next deep dive.